Dear colleague, dear moderator, I would like to thank the scientific committee for the invitation. I have no conflict of interest regarding renal replacement therapy, and the Akiki trial was funded by a grant from the French Ministry of Health. The question is very old, more than 50 years ago. As you can see, the optimal time of renal replacement therapy was a question when the context was the reversible acute kidney injury. And the cornerstone of this question is the reversibility of the renal failure. And the problem is it's impossible to predict the time to renal function recovery. So early renal replacement therapy initiations allow for better fluid balance control, improved acid bath status, better control of electrolytes abnormalities such as hyperkalemia, and maybe removal of toxins and cytokines during sepsis. However, renal replacement therapy is not devoid of risk. For example, catheter bloodstream infection, hypotension during the session, and metabolic abnormalities, for example, hypophosphatemia. And this technique is associated with increased cost. The available data on the timing are mainly, but most of them are observational studies. And the result of these observational studies led to conclude in the meta-analysis that an early RRT initiation was associated with a better prognosis than a delayed RRT initiation in terms of mortality. However, the observational study have major flaw to answer the question of the timing. And I will show you why. Patients presenting acute kidney injury in ICU could be separated in two categories. Patients managed with RRT, which could be early or late, and patients who will not receive renal replacement therapy, even in this context of severe acute kidney injury. And this patient will not receive renal replacement therapy, maybe because they will recover or because they will die before to receive renal replacement therapy. And the problem of the observational studies, the major flaw, is that they did not include the no RRT patients. And maybe these patients have a better prognosis than the other patients. So the adequate study design to answer the question is to compare strategies. The early strategies, in this strategy, all patients will receive renal replacement therapy, and a delayed RRT strategy or late RRT strategy. In this strategy, some patients will receive RRT because they will reach specific criteria, alert criteria, and other patients will not receive RRT because they will not reach this specific criteria. So to answer the question, we need to compare strategies and we need randomized controlled trial. Few randomized controlled trials have been published recently, and these trials are summarized in this table. As you can see, they are different in terms of setting, in terms of population. 3 of them took place in surgical ICU and mostly cardiac surgery, and 3 of them were small single-center randomized controlled trial. One of them, the ELAINE trial, was published next year and published in the JAMA journal. And as you can see, in this study, the delayed RRT strategy was associated with increased mortality after 90 days, but not after 30 or 60 days. In this study, the criteria to start RRT in the early group was KDIGO 2. And in the delayed RRT strategy group, it was KDIGO 3, which is a very small difference between the two groups. So, as expected, only 9% of patients in the delayed group did not receive RRT in the ELAINE trial. And the difference in terms of time to RRT between early and delayed group was very small, only 20 hours. When we look at the secondary outcome, we are very surprised to see that the duration of RRT is 9 days for the early group and 25 days for the delayed group. And the difference is very important for the hospital stay, more than 30 days in terms of difference. So these results led Paul Paleski, an expert in the field, to state in this letter that it is difficult to reconcile how such relatively small difference in the timing of initiation of RRT resulted in not only 4% reduction in the hazard ratio for death, but also reductions in median duration of RRT of more than 2 weeks and median duration of hospital stay of more than 4 weeks. And we know that the results of single-center trial must be viewed with caution because of center-specific effect, and we need multi-center randomized control trial to confirm the outcome in a single-center trial. So it is very good because we can compare ELAINE to the HEROIX trial, which is a French trial, very similar to ELAINE. HEROIX and ELAINE took place in surgical ICU, and mostly cardiac surgery. And the early group was a very early group. But HEROIX is a multi-center trial, so it is very interesting to compare the two trials. In the HEROIX trial, the patient received renal replacement therapy in the delayed group. In this context, severe hyperkalemia, oliguria for more than 1 day, urea concentration greater than 36 millimole per liters, and creatinine concentration greater than 352 micromole per liters. And with this criteria, 43% of patients in the standard group, the delayed group, did not receive RRT. And as you can see, the mortality did not differ. So we can conclude that the HEROIX trial invalidates the result of ELAINE trial. So we need large randomized control trial on severe AKI patients, and three large randomized control trials are summarized on this table, and the AKI trial was published, the first published last year, sorry. So we published this result in the New England Journal of Medicine. This trial includes 620 patients, and we compare an early and a delayed RRT strategy. In the delayed RRT strategy group, the criteria to start renal replacement therapy were severe hyperkalemia, severe acidosis, acute pulmonary edema due to fluid overload and responsible for a severe hypoxemia, oligoanuria for more than 3 days, and serum urea concentration greater than 40 millimole per liters. And as you can see with this criteria, almost 50% of patients in the delayed group did not receive RRT. And this is a very important difference between the two arms. The Kaplan-Meier showed that the mortality was very close between the two groups. There is no difference, no statistically different, but it is not a non-inferiority study. However, to detect an effect size of 1.2%, the difference in mortality that we found between the two groups, with a power of 90%, we should include more than 70,000 patients, which is impossible in ICU. For the secondary outcome, of course, the RRT 3 days were greater in the delayed RRT group, and the catheter bloodstream infections were greater in the early RRT strategy group. What about the renal function recovery? In the delayed strategy group, there is a more rapid renal function recovery when you look at the adequate urine output with no need for renal replacement therapy. So during the reviewing process, we were asked to do something, and I will explain you this problem. When you perform two-arm randomized control trial, you should compare the data according two groups of randomization. In HiKiki, it is the early RRT strategy group and the delayed RRT strategy group. Good science is to compare these two groups, but during the reviewing process, we were asked to artificially dividing patients in the delayed group as patients who actually receive RRT and patients who did not receive RRT. And after, one reviewer asked the comparison of the primary outcome between the patients who actually receive RRT in the delayed group and the whole population of the early RRT strategy group. And when we asked to our biostatistician to perform this analysis, he wanted to quit because he told that it was not good science to do this. Alors, so the comparison of the so-called subgroup of patients in the delayed group who actually receive RRT with the early group, the whole early group, is not interpretable for two reasons. An indication bias, patients who finally receive renal replacement therapy in the delayed group were those whose status worsened. It is a time variable confounding, and an immortal time bias. It is not possible to identify a patient in the delayed group who will actually receive RRT at the time of the inclusion, but not only at the end of the follow-up. So, looking for an interaction between SAP3 and RRT strategy, not excluding the no RRT patients, is more appropriate. When we look at the raw data and consider that the early strategy is a reference, look at the hazard ratio for death in the patients who actually receive RRT in the delayed group. It's 1.4, and the p-value is 0.01. So we can wrongly conclude that the best things to do is to start early. But when we look at these patients, the no RRT patients, the hazard ratio is 0.71, and the p-value is 0.03. So we will wrongly conclude that the best things to do is to never start renal replacement therapy. It's a nonsense. So after matching, the difference disappears, of course. And finally, a meta-analysis of a randomized controlled trial on this topic was recently published. And in this meta-analysis, there is no difference in terms of mortality between the early RRT strategy and the late RRT strategy. So the take-home message, we need to compare strategy, we need large randomized controlled trial. And RX invalidates the result of ELAIN trial. And now we can say that a conservative strategy might be considered as a standard. This strategy obviates the need for RRT in almost 50% of cases. The mortality did not differ significantly, and the renal function recovery was more rapid. We are waiting for the results of IDEAL ICU and START-ACAI, the Canadian trial. We need to accumulate the evidence to answer the question. I would like to thank the patients and their surrogates for the participation in the HiKiki trial. Professor Didier Dreyfus, the senior author of the HiKiki trial, Dr. David Ajaj, the biostatistician, and the DSMB, Laurent Brochard, Christian Mello, and Alexander Tig, and all study sites investigators for the HiKiki study group. Thank you very much for your attention.